So we have done already spinal cord, and now we start about the brain stem. In order to understand the brain stem, it is important to consider that brain stem is a cylindrical structure with a central canal with a cavity inside, and this brain stem is made up of three parts. First you have the midbrain, and then you have the pons, and then you have the medulla oblongata. Each of these brainstem is connected to the cerebellum via peduncles. Superior cerebellar peduncle will connect the midbrain with the cerebellum. Middle cerebellar peduncle will communicate the pons with the cerebellum, and inferior cerebellar peduncle will connect the medulla oblongata with the cerebellum. Concept number 2. In the year 2005, one neurosurgeon published the rule of 4 of brainstem. It's very important for diagnosing the neurological cases, and today first we will discuss about this rule of 4 so that you understand that in which part of the brainstem what lies and how we can use this to diagnose the neurosurgical cases. So if this is the cross section of any particular part of brainstem, and this is the midline, and obviously here you have the central cavity or the ventricle, whatever, then each half of the brainstem is essentially made up of two parts. This is the lateral part, or which occurs in the side, and this is the medial part, which is lying near the midline. Now this medial structure will have 4 M's. First M stands for motor pathway, which is the pyramidal tract or the corticospinal tract. Next M stands for medial lemniscus with sensory pathway. Third M stands for medial longitudinal fasciculus, and fourth M stands for cranial motor nuclei. It may be 3, it may be 4, it may be 6 or 12. And if you remember, all these represents general somatic efferent column or somatomotor column. 3, 4, 6, 12. So in the medial part of any brainstem, whether it is medulla or pons or midbrain, you have these 4 M structures: M for motor, M for medial lemniscus, M for medial longitudinal fasciculus, and M for cranial motor nuclei. If this is damaged, then you have contralateral hemiparesis, contralateral paralysis. If this is damaged, you have contralateral loss of vibration plus proprioception plus 2-point discrimination. If this is lost, you have ipsilateral intranuclear ophthalmoplegia, and if this is lost, then you have lesions depending upon the cranial nerve, all being ipsilateral. In the side we have 4 S. The first S stands for spinocerebellar. The second S stands for spinothalamic. The third S stands for sympathetic pathway, and the fourth S stands for sensory nucleus and sensory tract of trigeminal nerve. So we have 4S. S for side, S for 4S. So we have all the structures in the side. S for spinocerebellar, S for spinothalamic, S for sympathetic, and S for sensory nucleus of trigeminal nerve. If spinocerebellar is damaged, we have ataxia. If spinothalamic is damaged, we have loss of pain and temperature. If sympathetic is damaged, we have Horner syndrome. And if sensory tract, sensory nerve, the spinal nucleus, not sensory, this is spinal nucleus and spinal tract is damaged, then we have loss of facial sensation, loss of sensation over the face. So depending on this, we can diagnose that whether the lesion is in the medial side or whether the lesion is on the lateral side. Now out of all these things, this is ipsilateral, this is also ipsilateral, this is also ipsilateral, but this one will be contralateral. So these are the longitudinal tracts. So that means we have identified that if this is the brain stem and this is the cavity, this midline, so anything which affects towards the medial side and something there is in the lateral side. So we know in the medial side we have the 4M, and we know in the lateral side we have the 4S. So by these two things we can identify that whether the medial part of the brainstem is affected or the lateral part of the brainstem is affected. Now it is important to diagnose that which part of the brainstem is affected. Is it midbrain or pons or medulla? If it is midbrain, then 3 and 4 damage will be noticed. If it is pons, then 5, 6, 7, 8 damage will be noticed. If it is medulla, then 9, 10, 11, 12 damage will be noticed. Now here 8, as we know that 8 is in the pontomedullary junction, so 8 will be here also in the medulla. And we have also seen that 12th lies in the medial part, medial side. 12th, the 4th and the 6th, they lie in the medial part, so we'll just delete them off in the medial part. 3, 4, 6, 12, we'll delete them. So this 5, 7, 8, they will essentially lie in the lateral part of the pons, and 9, 10, 11, they will essentially lie, and 8 will essentially lie in the lateral part of the medulla. So that means this is a diagnosis of the latitude, means midbrain or pons or medulla by seeing the signs, and here this is the diagnosis of which side is it the medial side or the lateral side. So for example, if a patient comes to you with complaint of, say, paralysis on, say, right side, immediately you know that it is the medial part of brain stem is damaged. You're dealing with some problem is in the medial part of the brain stem and not lateral part, because medial part contains motor. You can see here medial part contains motor. Okay, so now we have to decide that whether it is in the midbrain or pons or medulla. If it is 3 or 4 is damaged, obviously it becomes in medulla. If the 6th is damaged, it is in pons, and if the 12th is damaged, it is in medulla. So if this patient, for example, if you have a concomitant loss of, say, third cranial nerve function, then the diagnosis becomes it is the problem of midbrain. If there is a problem in the 12th nerve, if there is a problem in the 12th